saying happy Rat Tech Week.
Thank
I
you.
hope everybody's enjoying the donuts and candy.
Oh,
I had salad yesterday. We had salad.
Okay.
Okay.
Look at that.
It was a cold shower.
Yeah, good.
You can shower on top of Rat Tech Week?
Yeah.
Where are you at?
If you can go,
Okay, good one.
Nike one of the nurses.
Oh, it's a nurse.
Okay.
Jasmine just decorated all the baby showers.
Yeah, so multiple celebrations in your computer. I think it's a time to reflect on, you know, the profession, and I appreciate what you guys have done. You're 3 years now. I hope you guys can really congratulate all the RTs out there this week. They don't get enough recognition as it is. So take the moment, kind of soak it in, because this is our week. We got lunch planned this afternoon with some door prizes and stuff like that. So bring your thinking cap, especially when it comes to like MRI type stuff. So I got some door prizes for you guys to win. But how's the week going? Yeah. Any other stuff besides just food, or is it just food?
They decorated the hallway a little bit.
Yeah.
At UH, yeah.
Yeah, sometimes they do like fun things. Around Halloween, they carve pumpkins. I know in the main hospital they have like a pumpkin carving contest.
Yeah, they did. Yeah, I couldn't catch it last week, but they did. They had pretty interesting
Our
things.
department for Christmas and Thanksgiving, we like decorate our door, and whoever had the best door would win like
The
prizes.
research building did that for Halloween, and the door that was like it.
It with the red balloons. I think I saw walking by. Anybody see any good scary movies recently?
No.
All right, so today we are going to be talking about contrast, and really the mechanisms behind how contrast enhances on our image. MRI is a modality. When do you think MRI really started? Like when did we first utilize MRI in the clinical setting? Like what decade?
Early 90s.
80s.
Early 90s? You think it's that new?
Yeah.
Okay. 80s? Well, it actually dates all the way back to the 70s. So MRI as a modality does date back to the 70s. And we obviously know that there's no ionizing radiation involved, and the contrast in our image is way better than other modalities. And you can attest that to your cross-section class. You guys remember having to identify images or anatomy on your sagittal MRI image, and then trying to identify those same anatomical structures on the axial CT, and how much tougher it was with the CT, because it's really just a tiny bit different shade of gray. But with MRI, we have a very high inherent contrast, meaning we can really differentiate between structures without the need of contrast. So at the beginning, like the infancy of MRI, there really was no need for contrast. It wasn't until about the 80s that they started developing these contrast materials. And what is the main element used in the contrast that we use today? Gadolinium. Anybody know the atomic number for gadolinium? So let's look at the periodic table. So gadolinium's down here. .64 is the atomic number for gadolinium. And what type of element is it? Is it a gas? Is it a metal? What is gadolinium?
No. Yeah.
Lanthanide? It's a rare earth metal. One where it labels the actual. So it's part of the lanthanide series down here. You see that? So gadolinium has 7 unpaired electrons. So in the outer shell, it doesn't have a complete set of electrons. So the properties of gadolinium make it paramagnetic. So remember we talked about the different levels of magnetism. We had diamagnetic, which does that attract or repel? It repels. Then we had paramagnetic and ferromagnetic. Ferromagnetic, remember, those are the things like iron we don't want to bring into our room because they're highly attracted to our magnetic field. But paramagnetic are slightly attracted to our magnetic field. All right. So I just want to talk about contrast and what you guys know so far. So it has our 7 unpaired electrons. It's paramagnetic. But do you know how and why contrast, when it's injected, appears bright on our MRI image? What do you think is happening? You guys have read ahead, or if you asked any technologists, what is going on with that gadolinium when it's interacting within our body?
Changes the relaxation time.
Perfect. Changes relaxation time. And remember, we have 2 types of relaxation. We have a T1 and a T2. Which one do you think it is? It's a T1. It can actually change the T2, but we benefit usually looking at a T1 image because pathology appears bright on our T1 image. So good. So let's just kind of do a general. So gadolinium, let's say, has 7 unpaired electrons, which makes it paramagnetic. Okay? So Rachel says it does something to our T1 relaxation time. So let's draw that T1 relaxation curve again. So we have our y-axis and our x-axis. So when we label this curve, what is our y-axis here for T1 relaxation time? What's that? B sub 0. Yeah, I mean, it does align with B sub 0. What is that magnetization field that aligns with B sub 0? MZ. Perfect. So M sub Z is our y-axis. And then our x-axis is just time. In time, usually in milliseconds, because that is a parameter for our pulse sequences. It's usually what our timing unit is. So let's label our graph again. So this is a T1 relaxation curve. We have a couple other names for it. Is it recovery or decay? Does our signal recover or decay?
Decay.
On T1.
Decay.
What's that?
And the decay.
Decay. T2 decay goes down. T1 is recover. So just remember, another name for T1 relaxation is T1 recovery. And then spin lattice or spin spit? Spin lattice, because we're dealing with the tissue lattice, which is the surrounding tissue. So remember, MRI is about making those associations, because this is the kind of questions that will be on the registry. So T1 relaxation curve, also known as T1 recovery, because our tissues are recovering back to 100%. And spin lattice, because we're talking about how our spins interact with the environment. So at the top of our curve here, we have 100% recovery. And then down here, we start at 0. So before contrast, we had very high inherent contrast within our image. And MRI usually has two main sequences, a T1 and a T2. Which one detected pathology better?
Which one is
Naturally detect, okay, because T2, because a lot of our pathologies are water-based. And what is bright on T2? It's fluid, yeah. So in the past, let's put over here, just a little history before contrast. We had very high inherent contrast, meaning we could visualize the different structures within the brain, abdomen, tissue at a very high rate. T2 was better for delineating pathology. And T1, what was that great for? Anatomy, because we have very high signal with T1s. T2 pathology, because fluid is bright. And fluid is usually associated with pathology. So we were doing all right for a while, but as our technology increased and demands on our radiologists increased, our spatial resolution got better, but also it was really hard to see these very fine pathologies. It could be, let's say, a metastatic lesion within the brain. Say our patient has like breast cancer, and they're trying to decide or find out if that breast cancer has metastasized to the brain. At the very early stages of the metastasis, sometimes those lesions are so small, it was hard to delineate on our T2 weighted image because that pathology was so small. So we had very high inherent contrast, but we were still not really able to see that small metastatic lesion. So that's why we kind of really needed to start coming up with some contrasts. So by the mid-80s, we were designing contrast, but then by late 1980s, we started to incorporate them into the clinical setting. Okay? So once contrast was introduced, it was gadolinium, but gadolinium being a metal, just like lead or mercury, things like that. Have you ever heard of lead poisoning? It's very toxic to our body. And sometimes they call it, when we're talking about the body, in vivo. So if you guys see that on like an article, that's what that means. What's in vitro mean? That's really dealing with like petri dishes when they're doing like lab tests outside the body. So gadolinium being very toxic, we can't just like inject direct gadolinium, liquid gadolinium, because that would kill the patient. So what they created were these chelates. So chelates make it safe to inject gadolinium. So they bind to the gadolinium, and some of these chelates wrap around the gadolinium completely, and those are called macrocyclic, meaning they are basically a complete circle around the gadolinium ion. And then sometimes we have a more open structure that are called linear agents, and we'll talk about that a little bit later. Which one do you think is more stable? Macrocyclic. And we'll talk about that a little bit later when we talk about diseases associated with gadolinium, like NSF, or now they're even talking more about gadolinium deposition within tissues. So that's a big subject, a big hot topic amongst radiology right now. They are noticing gadolinium deposition in tissues, even in healthy patients that have good kidney function, no breakdown in the blood-brain barrier. But we're trying to find out, does this accumulation of gadolinium within these tissues result in any clinical significance? Does it cause, a little bit of Parkinson's-type syndromes? Does it cause movement disorders? Does it cause nerve tingling, kind of like MS? That's what we're really researching now. We know that gadolinium is accumulating in the brain, but we'll talk about that a little bit later. So these chelates attach to our gadolinium. And the two types, macrocyclic versus linear. So a lot of people describe macrocyclic as almost a ring or cage-like, because they form a complete circle around that gadolinium ion. And then linear, just like our linear slopes, usually a straight line or open structure. All right, so now we have created this contrast, and it's safe to use in patients. We've tested it on rats and mice. Those are usually our first test subjects. And now we're ready to use it in clinic. So by the late 80s, early 90s, we're starting to inject humans with our gadolinium that has been attached to a chelate, which makes it safe to go into the body and excreted through what? What excretes our contrast, just like with iodine? What?
Our kidneys.
Our kidneys, yep. Our kidneys are the ones that are going to be doing all the work, filtering it from our blood, because remember, we're injecting into our vascular system, filters it, and then we excrete it through our urine. Okay? Some agents are excreted through the biliary system. What's an agent that you guys use in clinic now that we're looking at the liver specifically? The liver and the biliary ducts, where we have to do an abdomen image and then we keep them on the table a little bit longer, and then we do like a 15 to 20 minute film or image sequence after they've been injected with contrast. Do you remember, does anybody know what that contrast is?
No.
It starts with E.
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 There's a B in it. Anybody done an abdomen where they've really extended the time on the table after contrast to look at those biliary systems, see as the biliary ducts start to filter?
No.
Eovist. Okay. I think some of you've heard that term, right?
Oh yeah.
You've heard eovist. Okay. So we keep one contrast. We carry one contrast that is specifically excreted by the liver and the biliary system, hepatobiliary excretion, but it also gets filtered by the kidneys. All the other contrasts that we normally use are always excreted just by the kidneys. And what are the two contrasts that we use in clinic at Emory? We have two main contrasts. One for, don't have to worry about any type of hypersensitivity towards being allergic to it. What's that one? Prohance. And then we have one for the patients that might have had an allergic reaction before. So, and that deals with linear versus macrocyclic. One is more stable and is associated with less adverse reactions, and that is the dotamer. All right, so getting back to this gadolinium that has 7 unpaired electrons, which interacts with the tissue lattice. So we have 7 unpaired electrons here. And remember, in MRI, we're really looking at protium, that isotope of hydrogen, has that 1 proton, 0 neutrons, gives it that positive charge, right? So you can see here with these electron, the negative and the positive, they're going to interact, correct? So the hydrogen protium, this is going to be in the tissue lattice. So pretty much every tissue has hydrogen protons within them. Depending on the tissue, some have more than others. But as we inject this gadolinium that has 7 unpaired electrons, it's going to interact with the tissue lattice. So that is why this T1 curve is so specific, because this is a spin lattice curve. So let's draw a line and say in red here. So this is our pathology. This is a tumor, Arnold would say. This is a tumor. But this tumor is very small, and it is not visualized on a pre-T1 image. A metastatic tumor within the brain. It's so small, it's not delineated on our image. So then we inject our contrast. Our contrast, having those 7 unpaired electrons, interacts with the tissue lattice. And do you guys remember which tissues recovered quicker? Fat or water? Fat or water?
Water.
Recovered quicker?
Oh,
It's actually fat. Fat recovers quicker. So let's say this tumor is a lipoma. So here is, oh, you can't even see that curve. Let's go back. Let's put it in orange. So imagine this is fat. Fat recovers pretty quick compared to water. Let's draw water's curve. All right, so let's label all these now. So this is fat, and then this one is water. So see the contrast between this lipoma and fat? Not very much difference between the two structures. So as we image, they almost might have the same shade of gray or brightness. So the radiologist is not able to actually visualize that tumor. Fat being a large molecule, remember when I drew fat versus water? Water is just H2O, right? Water, it diffuses very rapidly, it tumbles very fast, so it doesn't interact with our magnetic field as much, so that's why it takes longer for it to recover. Compared to fat, fat is a very large molecule, it tumbles real slow, so it tumbles and it has almost the same precessional frequency as our static magnetic field, so it recovers a lot quicker because it's giving off energy to the environment faster. So this lipoma, having almost the same recovery curve as fat, is hard to see. So we inject the contrast, what do you think happens to this lipoma? Do you think this curve shifts over to the left, or does it shift this way to the right? What do you think? To give it more signal. So remember, this is a T1 weighted image. What's bright on a T1 weighted image? Fat or water? Fat, because it recovers quicker. So if I want more signal from a tissue, which way should I shift this curve? To the left or to the right towards water? Oh, you're mixed. So remember, water appears dark on a T1 weighted image. So we don't want this curve to shift to the right. We want it to shift to the left. So this curve now shifts to the left. Now I'm going to redraw my curve, and then it recovers. And then let's label it here. I'll make it a little smaller. This is tumor plus gadolinium. Okay? So we have shifted our tissue, that lipoma, to the left, meaning it recovers faster. So more of that vector is going to be able to get flipped down into our transverse plane, and we're going to get more signal from that structure. So that's why gadolinium do you think this is called a T1 agent or a T2 agent? T1 agent. So gadolinium is a T1 agent. Because let me show you what it does on our T2 curve. All right, so I'm going to draw my T2 curve down below. All right, so let's get our labels. So what's our y-axis for a T2 curve? It's not m sub z, it's m sub xy. We're drawing this in a two-dimensional fashion. Our x-axis is still time in milliseconds. We start at 100. Then our signal goes down to 0. All right, so let's label this graph. What are our other names for T2 relaxation curves? Okay. Good. So I am going to draw my tumor here. It decays at this rate all the way down to 0. So with a T2 curve, what do you think it does? If gadolinium is a T1 agent, meaning we are highlighting the pathology on a T1 weighted image, we're not really highlighting a pathology on a T2 weighted image, so which way does the curve shift post-contrast? If I shifted the curve this way, our signal decays faster, versus if I shift the curve this way, the signal decays slower. So which way is the curve going to shift post-contrast? actually going to be to the left here.
Before contrast?
So our curve
Oh,
post-contrast,
that's after contrast?
after,
Oh, yeah, after contrast. I'm talking about before.
is going to shift to the left. So if you have trouble remembering these things, just remember our curve for both T1 and T2 shift to the left towards our y-axis. So is our tumor with contrast going to appear hyper-intense or hypo-intense? It's going to be hypo because our signal is decaying faster. Because remember, this is a T2 decay. Our signal on a T1 is hyper, so let me actually label that. So our tumor with contrast is going to be hyper intense. That's why we usually always, post-contrast are going to be running pulse sequences that are T1. But then our tumor with contrast on a T2 is going to be hypo intense. Meaning our signal is going to go down and it's going to appear dark on a T2 weighted image. So anytime we have a hyperintensity with our T1, that's why it's called a T1 agent, because that tumor is going to appear bright. Okay. So remember the different names for the curves. Know what happens to our tissues as they're injected with gadolinium, which way the curve shifts for both T1 and T2. Okay? But remember, our gadolinium is a T1 agent, so we are going to be maximizing our signal from the tumor post-contrast. So it appears bright on our image. All right, let's just talk a little bit about gadolinium safety for a second. So we talked about how it is toxic unless it's chelated. So in 2006, there was a big study done that linked injection of contrast in renally impaired patients, meaning they were on dialysis, they had kidney failure, they had some kind of infection of their kidneys, maybe they had only one kidney, but they linked a disease to kidney failure and injection of contrast. Do you know what that disease was called? Had hardening of the skin and the tissues. A couple of patients died from it. NSF. So in 2006, NSF was linked to GAD injected in patients that were renal insufficient. And they were linked to a couple of contrast agents. Which contrast agents do you think they were linked to? Macrocyclic or linear? Linear, because it's a more open structure, meaning that there could be a breakdown in that chelate, and that gadolinium detaches from it, and then it remains in the body. And then if it remains in the body, just like lead poisoning, it could go into the tissues, harden those tissues, and cause them not to function properly. So NSF was associated with really thick skin, hardening of the tissues, unable to bend at the joints. And imagine if you got gadolinium in like your heart tissue, your heart might not beat appropriately, or your lungs, or your diaphragm might not be able to go up and down anymore. So a couple of patients actually died from NSF. So this was eye-opening because before, gadolinium was considered to be extremely safe contrast agent. Compared to iodine, where we know iodine, there's a lot of reactions associated with it. You know, most people with a shellfish allergy are allergic to iodine, right? Because there's iodine within shellfish. But gadolinium at the beginning, the reaction rates were like less than 1%. Not many people were reacting to it, and they didn't really have an issue with it until this link between NSF and the injection of gadolinium within renal insufficiency. So after this came about, the ACR made some guidelines and restrictions. So they made technologists check for patients that might be renally impaired. So what are the 3 lab tests that are really linked to our kidneys and how well our kidneys are functioning? Because if our kidneys can't filter out this contrast, it's going to stay within our body much longer, unless they have dialysis, right? And you guys, if you've been in the hospital, sometimes they have the patients go to dialysis after they inject the contrast, right? Have you heard them set that up?
Yeah.
They'll be like, make sure this patient goes and gets dialysis after the MRI procedure, and that's to make sure that they're filtering out this gadolinium. So what are some lab tests for our kidneys? Okay. eGFR, estimated. What are our range for eGFR? What's a good number to be above? There's not really a range. There's a number that a lot of MR techs check to make sure they're above. 30s, you want to make sure they're above 30 because below 30 means they're severely impaired in the kidneys. Below 15, they're renal failure. So anything below 30 is a big indicator of, I need to check maybe with a radiologist to see if we should do this procedure. Here at Emory, they've decided pretty much everybody can get gadolinium because they've done the research on what type of contrast agents are the safest. And usually if they have a renally impaired patient, they make sure that dialysis is set up for the post-procedure. But some places you might work at, and they'll do lab tests, and if it's eGFR below 30, they'll not do contrast. They'll do the MRI, but it'll be a contraindication for contrast. So anything above 30 is usually okay, but the main one for healthy patients is usually above 60. And the unit is milliliters per minute per 0.13 meters squared. So very specific unit. So we need another lab value to actually calculate eGFR. What is that other lab value we need for the kidneys? Good. Serum Creatinine. Does anybody know the ranges for that? That's a range.
0.6 to 1.2.
Sorry. 6 to what? What did you say? A range?
1.2.
1.5. But close. And this is milligrams per deciliter. So to calculate our eGFR, if you have the little pinprick of the finger, you run it through your little lab test. You usually need the serum creatinine, and then you also need the age of the patient and the race of the patient to calculate the eGFR. So to calculate, so let's put that off to the side. So we need the serum creatinine and the age of the patient and the race. So there are eGFR calculators on Google. So if you don't know how to calculate for it, just go to calculate eGFR in Google, and then they have the calculators where you get the serum creatinine readout, put in their age, and put in their race, and then it produces your creatinine. All right, what's the third lab test that really tests kidney function? The UN. And what are our ranges there?
8 to 20.
8 to 20, good. And this is, once again, milligrams per deciliter. So what's the GFR we really are concerned with? Below what? Below what? 30. 30 to 60, we're a little concerned. Above 60, we're doing good. Okay? You calculate the eGFR from the serum creatinine and two other things. What are the two other things?
Age and race.
Age and race. Make sure you get the patient's age and their race. Go to Google and just find an eGFR calculator. But most of the little readouts for the labs come with the eGFR and creatinine already on there. That's why most screening forms will ask, have you ever had any kidney impairments? So that's a big question to make sure that they're answering appropriately is if they've ever had kidney surgery, if they have one kidney, are they on dialysis? Have they ever experienced chronic kidney failure? Sickle cell patients also usually have issues with their kidneys, things like that. All right. So if your patient has a minor reaction, what's a minor reaction called? So you put them in, you inject the contrast, and you see that they have hives on their neck or their chest. Is that systemic or non-systemic? Non-systemic. What do you think you do in that case? You just send them home? What do you do?
Radiology.
Call the radiologist, good. And then the radiologist usually consults with them just to see how bad the reaction is. If the reaction's bad enough that they need to see a nurse or a doctor, they'll send them usually to the ER. But if it's a small reaction, just an acute reaction, non-systemic, they might tell them just stop by CVS and get some Benadryl on the way home. And I've seen that happen, so it happens. Do you guys ever inject, say you're at an outpatient facility and your radiologist leaves at 4 o'clock and you have a contrast exam at 5 o'clock, do you inject gadolinium? Exactly, because you need to have a MD in the building just in case something like that happens. So be mindful that if you are working at a place where there are radiologists that typically leave at like a certain time and you're still scanning. So like if you have ever rotated through an outpatient clinic, don't you notice that like past 4 or 5 o'clock, those are mostly non-gadolinium exams, right? They're just like knees and shoulders, things like that. Because you need to have an MD there just in case the reaction happens. Okay? And if for some reason a reaction happens and there's no MD and you're at it, what do? Reschedule? No, you've already injected them and they have a reaction.
Oh,
What do?
with no reason.
Call 911. Just,
Oh.
yeah, call 911. You know? Good. Anybody have any questions about that? Has anybody seen a reaction in clinic yet? Small reaction, highs? What happened?
Patient started vomiting everywhere, like real bad,
Okay.
from after we injected the contrast.
Where was this at? MOT?
Mm-hmm.
Did you guys give Gadolinium or did you give Progan?
We actually did give Gadolinium because they had a reaction before, so we gave them Gadolinium, and she still had a reaction.
Okay. But didn't get any redness or
No.
swelling? Just it was more of just a
Just
throwing up?
vomiting, yeah.
Okay. What did you guys do in that situation?
We just took out the scanner, let her sit up to the side, and gave her a bag and let her throw up. Just let her finish throwing up.
And
give
did she
her a
preempt you guys and saying last time she threw up, so you had like an emesis
Yeah.
basin ready and everything?
Yeah, we knew that she was, so we was watching her. Her reaction was a little delayed, so it didn't happen right after she got the injection.
Yeah.
But we knew that she had a reaction before, like with throwing up, so we were prepared to go back in there. So as soon as she squeezed the ball, we just went in there. We already knew.
Good. So you guys are prepared. All right, so after you have had a reaction, what do you do with the patient's chart? What's good standard practice for an RT? What should you do? Document. You have your electronic chart, but if you have an actual physical chart, you need to put that in the patient's chart. Because you're trying to help out the tech that does the next scan, right? If you guys aren't documenting either your devices that are in the body or any type of prior reaction, you're not doing your part to help out the next step. Because that's a big thing within MRI department right now is a lot of people aren't documenting the devices that they spend 30 minutes looking up if it's safe to go into the machine. You did all that research, and then they come in a year later, and the tech has to do it all over again. So make sure you guys document any allergic reaction, but also the devices that are in the patient's body. Because a lot of people sometimes do a lot of research that is not necessary because it's already been done before. But they don't know that, it's not documented anywhere. So to increase the workflow, make sure you guys are documenting. What are the things you document from the vial? What are the things that you need to document? Lot number and expiration. So if it's expired, do we inject?
No.
Okay. If it's opened in some way or damaged, do we inject?
About the open one, I've seen techs reuse vials, like,
Okay.
like they would have like a 20 ml one,
Yep.
and they use 15.
Yeah.
And this happens at open, like they have like a bunch of them everywhere.
And that's fine as long as you're
Yeah.
cleaning like off your syringe, making sure, because it is sterile
Right.
within there.
Mm-hmm.
And you're using a sterile needle, but if you somehow, like if you touch the top rubber or if the top comes off and room air gets into the vial, then you shouldn't be using it.
But otherwise, it's fine.
Yeah, because
Okay.
it's a cost thing at that point. 'Cause
Yeah.
if they only have like the big vials, they're not just going to use like only 5 cc's and then throw it out, right?
Yeah,
That's a big
makes
waste of
sense. Yeah, it's just
Yeah.
a waste otherwise.
So, you want to utilize and be cost efficient with these things. All right, so let me see if I can save this page. Any questions? You guys got this written
Oh, I
down?
did have one more question.
Yeah.
actually. So when I was at OPIC, we did have a patient that was on the schedule, and on her chart it said that she had previously had a reaction to gadolinium, but apparently she came pre-medicated, so she was good, and we scanned her, and gave her gadolinium and it was no problem.
Yeah.
So what exactly, like, how are they pre-medicating with? What did they doing?
Just basically with Benadryl.
Oh, really?
Yeah.
Okay.
So it's to lessen the reaction.
Yeah.
And sometimes, if you've noticed, they might say, I'm allergic to gadolinium, but you ask them, have you had an MRI scan before? And they say no. What do you think they're allergic to?
Iodine.
They think it's a CT, so make sure if they say, yeah, I am allergic to gadolinium, make sure that they've had an MRI before. Because they commonly mistake MRI and CT, as we know, because you're going just in a little donut, and they think it's iodine. So just specify, oh, this is a different type of contrast, but we'll go ahead and use a safer contrast. Since you're hypoallergic to contrast to start with, we're going to go ahead and give you the dodorant just to be safe. Okay? Let's save this. Let's take a quick break. Let's take like a 10-minute break, and then we'll pick up on our lecture. Alright, so let's get back at it. Make sure to let me know at 11 o'clock to...
I have an alarm.
You got alarms set?
Oh my god. He told us. Oh.
But I want to make sure I cover this, but I put on Canvas a couple of articles I want you guys to look at before next class. And I'm doing my thesis on gadolinium deposition, so it's kind of a big topic of mine. But I've seen some great articles out there that really describe kind of the current state of all the research and everything. So this is a great article that came out pretty recently that really summarizes everything that has gone on research-wise with gadolinium, all the way back to when I was talking about NSF, even earlier than that, animal studies that happened in the 1990s, all the way up to what we're talking about today, like some technology, some imaging techniques to reduce the amount of gadolinium that we're injecting in the patient. It's pretty cool. They have artificial intelligence. You guys have heard about AI, right? AI is being used with those deep learning algorithms to create what we call synthetic MR images, where we're injecting only 10% of the gadolinium, and then the AI, the algorithms and the technology can make the image look like a full dose gadolinium image. So that's kind of one thing that's going on. Another thing is arterial spin labeling. We'll talk about in functional MRI. They're using that instead of injecting gadolinium to produce MRA type images. So a lot of these imaging techniques that they're coming up with are ways to reduce or completely eliminate the need for gadolinium. So it's kind of the future until we really figure out what are the clinical ramifications of gadolinium in the patient. So that's pretty cool to hear about that. So I have that article and this one. This is one from 2018, so only a year old, but two great literature reviews to look at. And I know you guys are working on your papers, and some of this might hit on with MRI safety. I don't know if you're talking about contraindicated devices, but these are kind of good things to kind of really start to see what a literature review looks like too, and how to like comprise and organize that. How are your papers going, by the way? What do you guys have to do by the end of the semester?
We're sharing our final project, our final phase research outline, sources, research strategy.
Yeah. So my main strategy, anytime I start on a paper, is I find a great literature review, like either one of these, and then I just cruise all the way down to the references and look at the titles of the references and go, man, that article sounds like it could be something that would be relevant to my paper. So I think that's a great way to really boost up your reference list. So if you are struggling to find good articles, you know, sometimes you type in your databases, you have these keywords, and then it comes up with 1,000 lit reviews or articles, and you're like, oh, how can I narrow this down? I like to find one good literature review and then just pick and choose some of the best articles from that literature review to help kind of write my paper. So if that helps, that's something I've really found very helpful in the writing process. But these two articles talk about gadolinium deposition, and then I had one other article. Oh, it's underneath here. This is in our ASRT journal, and this one's talking about NSF. And this one dates back to, I think, 2017. So very new, very recent articles. You know, anytime you're doing research, you kind of want to use the latest and greatest when it comes to the research, because if you find an article that was published in 1992, I guarantee you they've expanded on the research, or they've corrected it, or improved. You know, there are things that have happened between 1992 and 2019. So anytime you're looking at articles, make sure you're using the links, okay? So most of the time when you're doing a literature review, they like to have a time frame between the last 5 years is usually your limit. 5, sometimes they expand it to 10 if you're doing a little bit more like history-based. So make sure to read those 3 articles, because we're going to discuss them, and we're going to like break up into groups and kind of like talk about what you learned from like gadolinium deposition and NSF next week after we finish our lecture. All right, so let's go through the PowerPoint. We're not going to get through it all today because we only got about 50 minutes left. But we've talked about most of these things in the review that I did for the first hour of this lecture. Let me make sure I'm still recording. Okay. All right, so contrast is used to aid in the diagnosis of tumors, infection, infarction, post-traumatic lesions in the central nervous system, and basically anywhere in the body. So in the brain, we inject contrast. What are some other things besides tumor and infection? What are some reasons that we inject contrast? Young female patient, tingling in her fingers, what? MS. That's good, those little MS lesions. What about in the spine? What do we look for with contrast? In MS again, we could do MS. What's the one where we get the fluid running down the middle of the spinal cord? Serous. What else? Do we ever do like an L spine? For herniated disc, do we do contrast?
No.
No. The only time we do contrast for like a herniated disc is if they've already had surgery. Post-surgery, they come back and they're trying to differentiate between scar tissue and a re-herniation of the disc. So make sure you, if it is looking for an HNP, it's really post-laminectomy, post-fusion, where they're looking to see if the scar, if it's the scar tissue impinging on the cord, or if it's the disc has re-herniated. What about in the body? Abdomen, chest.
Abdomen, yeah.
Abdomen. Liver lesions, those are a big thing. Any type of lesion within the MRAs of the abdominal aorta. Not necessarily stones, because stones are pretty hard. They'll show up on X-ray too, and CT. So stones might actually be for another modality. But if it is stones, sometimes they're like reevaluating and seeing if the stones have gone through their system. Cysts, infection in the abdomen, things like that. Looking at the bowel, we'll talk about in interrography, they have to drink a certain contrast. Do you guys even remember the name of the contrast that they drink? Starts with a V. Has anyone done an interrography?
I've seen
one? They've changed the protocol a little bit recently. Panit has changed the protocol, so I don't know if they're still drinking all the contrast, but the volumen is the contrast that enhances the abdomen. So make sure you know that. Volumen is the contrast for an interrography procedure. And typically, at some places, they want to slow down the peristalsis, so they inject, what's the agent that slows down peristalsis, meaning the movement of the bowel? Glucagon, yeah. So we inject it, slows down peristalsis, we have the patient drink volumen, and then we image their small bowel.
What is the type of exam that they use?
Interrography. intraocular. All right, so how does contrast work? They broaden the tissue contrast displayed on the image. So they shorten our T1 relaxation time, and then they shorten our T2 decay time. So T1 is going to be bright, T2 is going to be dark. Remember from our curves. So in this instance right here, we're increasing our signal or our contrast to noise ratio. Which one do you think? When we inject contrast, do we increase our signal of our image? Do we get more signal? No. So we increase our C and R. So different tissues are going to be broadened. So here, fat and the tumor were not very broad. They were very close in relaxation times. So we have now shifted this curve to the left. So imagine this red line wasn't here anymore, and then these two tissues are now broadened, and we can really differentiate fat from the tumor. That's what it means to increase our contrast to noise ratio. We're broadening the tissues. Contrast. So we talked about water has high signal in T2. Most pathologies are T2, seen on T2. Some pathologies are difficult to detect, so that's why we need the contrast. These relaxation times are intrinsic. Remember going back to our parameters tab? Intrinsic parameters are things we cannot control. We can inject contrast, which causes to relax a little bit quicker, but that's not really something we can control too much. That's really just kind of the interactions within the body. We can't control the proton density of the tissue, meaning how many hydrogen protons are within each tissue. So these are things that are inherent to either the patient or with our magnet we can't control. Intrinsic parameters, those are things that we can manipulate for our pulse sequence. Remember, we can change our TR, our TE, our TI, our flip angle, things that will affect our pulse sequence. So these next couple slides are really just a review. So proton density, for proton density weighted, do we want to have a high TR or a low TR? High TR, and what about TE?
Short.
Short TE. So good. So from this slide, the most important stuff is having a high or intermediate TR, let's just say high, and a low TE. Okay? So that's to downplay the effects of T1 and T2. So going back to our curve, to get a proton density weighted image, we select a TE that is really short. So we would select a TE that's very short so that the tissues haven't had a chance to differentiate from each other. And then we would select a very high TR so that all the tissues have fully recovered and we don't get differentiation between the tissues. So we are just based off of how many hydrogen protons are within the tissue. This is what an image typically looks like. Remember, a grayscale image, we talked about that, where the fluid within the ventricles is bright, but not very bright like a T2, and it's not dark like a T1. You can see white and gray matter very well. Which is the white and which is the gray matter?
The white is the dark.
Good. White is closer to the corpus callosum because corpus callosum is a white matter structure. So it's kind of confusing because Rachel said the darker one is the white matter. So just try and get those associated in your head. But it's a very grayscale image. Do we do proton densities in the brain anymore? It's been replaced by a pulse sequence. What's the pulse sequence that's been replaced by? It nulls fluid within the ventricles. Flare. Flare shows the white and gray matter very well too, and then it darkens the ventricles so that we can see those MS lesions that sit right up against the corpus callosum. This is just talking about our T2 decay curve. We talked about this. But remember your percentages. A tissue is considered fully decayed when we only have 37% of our transverse magnetization left. So if I draw that line on this one right here, it's kind of weird because it's like our T2 decay here. So we have 37% left of our transverse magnetization. Or it has decayed by how much? Or it's decayed by 63%. So make sure you get the wording right on the test. T1 recovery, a tissue is considered fully recovered when it has reached 63%. So going back to our T1 curve, here's 100%. Let's go about 2/3 from that. So for all these tissues, it's considered fully recovered at 63%. What is the parameter that controls T1 and what is the parameter that controls T2?
T1 is TR.
TR. So we have multiple TRs here, depending on what the tissue is. And then you have multiple TEs here for T2. What's TE stand for again? Echo time. What's TR stand for? Repetition time is from 90 to what? 90 to the next 90. TE's from 90 to
1/8.
that's tau. That's half a T. It's a peak echo. 90 to peak echo. So see how everything's kind of slowly coming together? So this slide is just saying our contrast medium is able to affect our T1 and our T2 relaxation times. There's agents with different varying magnetic susceptibilities too. And we'll talk about relaxivity here in a little bit. So a T1 agent is going to shorten our T1 time. And a T2 agent is really, we're thinking about shortening our T2 time and it's going to appear dark on our T2 weighted images. So I've already drawn these curves before. This is just kind of a little reminder there. All right, and then this is a slide talking about the type of contrast we're using, which is gadolinium. Gadolinium is considered a rare earth ferromagnetic metal, very toxic to our body. The atomic number is 64. It has 7 unpaired electrons. The only way we can inject gadolinium is to attach it or bind it to a chelate, to other chemicals. It's actually an acid that it attaches to. So it neutralizes that metal.
So a chelate is an acid or no?
Chelate's really the glue that binds it to an acid. But some people kind of interchange that wording. It really is it's an acid, or ligand. The acids are called a ligand, but sometimes they refer to the ligand and the chelate almost as the same thing. But if you want to get real specific, the chelate's almost the glue that attaches it to the ligand. So let me write that down. So the chelate is basically the glue that ligand to our gadolinium. So it makes it safe to inject in the body, and it basically attaches it the entire time it's in vivo and excreted out of the kidneys and out of the urine. So if you see ligand and chelate, sometimes in those review articles that you'll read, you'll see those interchangeable. Gadolinium at body temperature. What's body temperature? 98.6. It's paramagnetic, meaning it has a slight attraction to our static magnetic field, denoted at B sub 0. So it's going to shorten our T1 relaxation time. That's why it's called a T1 agent. Gadolinium also shortens T2 times, but remember, on a T2 it's going to appear dark. That's why it's not called a T2 agent. There are contrast agents that are supra-paramagnetic, like iron oxide agents used in the liver, where we're actually going to create a signal void from the contrast that we inject. These contrasts are not really utilized in clinic anymore. So we're really going to be just focused on our gadolinium-based contrast agents. So remember, we said intrinsic parameters we can't really control because it's dealing with tissue relaxation. The only thing that we can really do is as we inject our contrast, we can make modifications in the local magnetic fields, which alter our T1 and our T2, so it shifts those curves. So that gadolinium messes with the local magnetic field as you inject it. So the local magnetic field, as it goes into the patient's body and around, that's why we're getting that shift in the curve. Temperature is really dealing with like viscosity. So anytime we warm up a contrast, what happens to our viscosity? So it's more like syrup, or it's less like syrup?
Less.
Less like syrup. So it decreases our viscosity. Okay. So here we're talking about the tumbling. So we inject the contrast into the tissue. Water typically tumbles very fast, right? It's a very small molecule. You put it in a beaker, water just flows rapidly. It moves every which way. You put fat in a beaker, it just sits there. It's like a glob of fat. It's not moving anywhere. So that glob of fat tumbled a lot slower, so it interacted with the tissue around it a lot more. That's why it was called spin lattice when we were dealing with fat, because it's giving off energy as it slowly tumbles around to the lattice, so it recovers faster. Water doesn't interact with the lattice as much because it's moving too quick, so it doesn't give off energy and it relaxes a lot slower. That's why T1 fat recovers a lot quicker. But when you inject contrast into the tissue, water, because you have that hydrogen proton attached to water, starts to interact with that gadolinium that's sitting within the lattice. And remember, gadolinium has those 7 unpaired electrons. So that negative electron and the positive of the hydrogen proton within the water, it starts to affect the local magnetic field, and that water that tumbled very rapidly to begin with starts to slow down. It slows down just like almost like fat to the point where it's going to relax a lot quicker now. So the tumor, which is water-based, is going to appear bright. So when we inject contrast, our water and our tumbling rate slows down so that it interacts with the magnetic field a lot more, gives off energy quicker, and it relaxes faster. So that's why our T1 curve shifts to the left. So going back to here, our water, which is the tumor, because most tumors are water-based, slows down, gives off energy to the lattice faster, and it relaxes a lot quicker. So that's what's going on when we're injecting contrast. We're shortening that T1 relaxation time. And what's happening is having a dipole-electron interaction. Dipole-dipole interactions, that's just basically meaning we got a positive and a negative interact. Some also call it a proton, PEDI, which stands for proton, electron, dipole interaction. Because we have the positive from the hydrogen protium within water, and then the negative from the electrons of gadolinium, those 7 unpaired electrons. Two positives do what? Repel. Positive and negative attract. So the main thing here is that dipole-dipole interaction causes water to process closer to the Larmor frequency, and when we have a better exchange of energy, if something's processing closer to our static magnetic field, we're going to give off energy more efficiently. That's why it relaxes faster. We have different properties of matter dealing with their magnetism. We talked about diamagnetic, which repels. Paramagnetic, slightly attracted. Superparamagnetic, a little bit more attracted. And then ferromagnetic, it actually gets attracted and it maintains that magnetic field even when you pull away that metal. So imagine iron gets into the room. It gets sucked into the bore of the magnet. Somehow you're able to take off that iron from our superconducting magnet. It stays magnetized. That's what ferromagnetic means. It's strongly attracted, but it also stays magnetized even when you remove it. That's how a lot of those permanent magnets are made. So basically, put a really strong magnet next to our permanent magnets, give it that magnetic strength, and then remove the original magnet. And it gives it that really strong magnetic field. So I put down here in the notes different things that are diamagnetic. Diamagnetic, gold and silver. So if you guys seen a technologist, you know, patient's like, I got my necklace on, is that gonna be attracted to the magnet? And they always ask, is that real gold? And it's almost insulting to the patient, but it's not that they're trying to say, like, you know, they want to know what the material is that the necklace is made out of, because if it is gold, it's not going to mess with the magnetic field. You should be taking these things off, but have you guys seen some techs not take off a gold necklace before? That's why. You're like, oh my God, why? It seems like we're putting in a metal necklace. But gold and silver are not attracted to our magnetic field. They repel. And we'll talk about a super paramagnetic iron oxide here in a second. So these different magnetic susceptibilities affect the local magnetic field differently. Some are stronger than others, so they're going to create a better or a more broad difference between those tissues. Gadolinium is a T1 agent because pathology appears bright on our T1 weighted images. And once again, our atomic number for gadolinium is 64. 7 unpaired electrons. Lanthanide metal. You guys remember doing the shells of the electrons, 2 and 8. So remember how that all works, right? So here we have a pediatric patient injected with gadolinium. Here is the tumor. It's bright with contrast because it has shifted over our T1 relaxation curve. This tumor might not have been visualized, especially with a higher signal intensity on a T1 weighted image. But you would have saw that tumor on a T2 because it would have been bright. But most tumors are not this big. They could be small little metastatic tumors. So other T1 agents, we have manganese. This is used for liver imaging. And hyperpolarized helium. So helium, we actually inhale it because the lungs are really not a good tissue for MRI to image because it's really just air, right? So if you had to choose a modality for the lungs, what would it be? CT. CT or even X-ray, because you're able to see those interstitial lung markings very well. MRI, not so much because we don't have many of those hydrogen protons within those interstitial lung markings. So sometimes we need a contrast agent like hypopolarized helium to better visualize the lungs. The lobes of the lungs, the interstitial markings, the bronchioles, all those things. Superparamagnetic agents, these agents are going to be shortening the T2 times. So remember, back to our T2 curve, superparamagnetics are going to shorten T2 times, so this tissue now appears darker on our image. So instead of appearing brighter, we inject the contrast, and now the pathology actually loses signal compared to increasing our signal. So this Faradex is a T2 agent, and we're really looking at signal reduction of that pathology. Another type of imaging that utilizes signal decrease when we inject contrast is perfusion scans. So if you guys have done a perfusion brain, we're basically injecting very fast and a lot of contrast, and we're watching the signal that is at equilibrium drop rapidly as the contrast goes in, and then the contrast flushes out of the system and it recovers. So a lot of times when we're doing these perfusion scans, these are the curves that come up. So let me just draw what's happening. So we have, for our x-axis, This is going to be, once again, time. And then our y-axis is going to be signal intensity. So we usually start off on an equilibrium phase. This is before the contrast gets injected. So most of the time when you guys have done perfusions, don't you start the pulse sequence, start first, and then inject? Haven't you seen that? So that's what's happening. You have an equilibrium phase. The contrast goes into the tissue, drops our signal intensity. It hits a peak, and then it starts to recover back to equilibrium. So what are these perfusion scans? It basically measures all these different slopes. And what that creates is an image and it's colored. Has anybody Googled perfusion scans, things like that? You get a very colored and detailed mapping of the perfusion in the brain. So if we just quickly Google perfusion brain, this is what comes up. So that graph that I just drew gets inputted into these mathematical formulas, post-processing, and it comes up with an image that looks like this. So this tells me how different structures are perfusing faster than others. So if you have like an infarct or an area that is restricted, the blood flow might not be getting to that area, and it causes it to look dark. You see that? So sometimes they do these for post-radiation, post-infarct, looking at tumors, so they can further assess and better diagnose the patients. But getting back to why perfusion is a T2, because perfusion, the signal intensity drops, just like a T2 agent. So here, our signal intensity is going decaying a lot faster with our contrast, just like with perfusion scans. So it's almost utilizing the same imaging parameters. So once again, Faradex is not really used that much in clinic anymore, but they still ask some questions about it on the registry. That's why I include it. But for safety reasons, iron levels occur 1 day after administration. These values are usually elevated 7 days post-injection. If there are side effects, here are some of the side effects that could be an issue. Back pain, leg pain, groin pain, head and neck pain, nausea, vomiting, diarrhea, hypotension. So you can see why it's not really utilized in clinic anymore. So these are the contraindications, so if they're allergic or hypersensitive to iron. And this is the dose. All right. Relaxivity. So let's talk about how bright that pathology looks on MRI. So before we went to ProHance, do you remember what the contrast was before?
Multi-hands.
Multi-hands. And just from the name, which one do you think appears brighter? If you had to inject 10 cc's of contrast, the two contrasts, which one's going to appear brighter on a T1 image? Multiple hand enhancing. Yeah, from the name, it has a higher relaxivity than ProHance. The only downside to ProHance, that's why we changed, it's not as stable. And remember, we're concerned about gadolinium deposition in the patients, so Emory went ahead and made the move to a more stable agent to make sure that they're counteracting any possible clinical ramifications of our gadolinium deposition. But multi-hands has a higher relaxivity. So what relaxivity means, so imagine we have two different contrast agents. This curve right here is multi-hands. It has shifted our T1 curve way over here. We're injecting 10 cc's of this multi-hands. Okay? Now let's inject 10 cc's of our pro-hands and see what happens. It doesn't shift it as far to the left. So this orange curve is 10 cc's of pro-hands. Meaning multi-hands has a higher relaxivity. The tissue relaxes a lot faster than pro-hands at the same dose. So if we're using 10 cc's of pro-hands versus 10 cc's of multi-hands, multi-hands is going to appear brighter on our image. So which contrast do you think the radiologist liked? Multi-hands. So there was a big, protest from going from multi-hands to pro-hands because the radiologist really liked that extra signal because we were able to see those small metastatic lesions a little bit better. But the issue with gadolinium deposition, that's a major indicator of why we switch to a more stable agent. Okay? Multi-hands is stable, but it's not as stable as pro-hands and Gadolinium. So we sacrifice a little bit of increased signal within the tumor or pathology by having a more stable agent so that we don't have as much gadolinium deposition with these patients. Because we know if a patient has like MS, how many times do they get an MRI scan? Throughout their lifetime, right? And usually it's a contrast enhanced one almost every year because they're assessing how bad those MS lesions are getting. Are they progressing, or is the medication slowing down those MS lesions? So these patients are continuously getting gadolinium, so we want to reduce the amount that's being retained within their body. The recommended dose for gadolinium, this is just a number you're going to have to remember. This is always on the registry. Highlight this on this slide, 0.1 millimole per kilogram. Of body weight. So MR techs make the quick conversion usually of 10 pounds per 1 cc. Some agents have been approved up to 0.3 millimoles per kilogram. But it's important to remember the lethal dose, highlight this, the lethal dose is 6 to 20 millimoles per kilogram. This is at one time. And obviously they've done the studies on these poor rats and found the half lethal dose. But the lethal dose is 6 to 20. So it's our responsibility to choose the right contrast agent. We start off with pro-hands. If they have any type of sensitivity, we switch it over to Gadolinium. We need to calculate the dose correctly. And if you're having to decide between one or two, I would go with a little bit lower dose. Like if you're right in the middle on a patient's weight, go with the lower because we don't know what's going on with this gadolinium deposition. Okay? You're going to get the enhancement, 0.5 cc or 1 cc is not going to make that much of a difference in the whole realm of things. But go ahead and give them the low, especially on patients that have repeated examinations. Those MS patients, those cancer patients. If it's their first time, maybe give them that extra cc. Okay? You guys can make that decision. But document how much you give them, the lot number, the expiration date, and the type of contrast. You should be putting that into the actual scanner too. As right as you come up to the injection, make sure you're typing that in, because that gets put into PACS. And we know the radiologists don't always look at all the tech notes. So make sure you're documenting in both places. All right, so let's stop there, and we'll pick it up from slide 38 when we talk about gadolinium stain. But those articles are on Canvas, so take a look at those, read those before we meet for class next time. We'll break up and discuss those articles and what you're doing.